Morning, everybody. My name is Jordan Lassetti. I'm the Chief Operating Officer of Umoja Food for Health, and I am excited to be here introducing the panel discussion on empowering patients through public health. Before we get started, just a little bit about Umoja. It means unity in Swahili. It's a question I often get asked. We are a certified minority food and logistics business with a social mission. So all of the work that we do revolves around addressing food insecurity, social determinants of health, and utilizing food for the prevention and treatment of chronic health conditions. We are a national organization headquartered in Chicago, Illinois, with brick and mortar offices and distribution centers in Pittsburgh, Pennsylvania, Houston, Texas, and Sacramento, California. And we work with insurance companies and healthcare providers all across the country to implement private labeled food as medicine programs on their behalf, including medically tailored meals, both frozen and shelf stable, medically supportive groceries, and produce prescriptions. And we're really passionate about nutrition education and coupling that with our healthy food delivery to drive better health outcomes for the recipients and better economic outcomes for our customers. Last thing I want to mention is we take a very hands-on approach to crafting our programs. We want to be very intentional. We want to be very mindful of cultural considerations, religious considerations, and any dietary restrictions when we put these programs together. So myself and my colleague Megan Guillory are at booth 18 all day, and we'd love for you to stop by, say hello, and spend a little bit more time chatting on who we are and what we do. So thank you very much. With that, with us today, this morning's opening session is Assembly Member Amy Paulin. Since 2001, the Assembly Member has served the 88th New York State Assembly District, and she currently chairs the Assembly Committee on Health and serves on the committees on Rules and Education. The Assembly Member has a long, distinguished record of activism in public policy and community issues and is one of the most prolific legislators in the legislature. Over 350 of her bills have been signed into law to date. Among her most important legislative accomplishments include writing and sponsoring the bill that eliminated the statute of limitations for rape, sponsoring the landmark Trafficking Victims Protection and Justice Act, and authoring the Birth Control Access Act. Also with us is Neenah Bland, the Executive Director of Albany Community Action Partnership, whose mission focuses on moving families toward economic mobility and an improved quality of life. Neenah has been with ACAP for nearly 20 years, the last 9 of which as its Executive Director. Last but certainly not least, we have Sarah Ravenhall, the Executive Director at the New York State Association of County Health Officials, which represents all 58 local health departments in the state of New York. Prior to joining the association, Sarah led the Population Health Improvement Program at Nassau-Suffolk Hospital Council. And moderating today's session is Roberta Rifkin, Senior Vice President of Government Affairs and Strategic Partnerships for Independent Health. And as a reminder, all of the panelists, as well as the moderators' full biographies are available in the conference app. So without further ado, I will turn it over to Dr. Schwartz, Ms. Rifkin, for empowering patients through public health.
Thank you, Jordan. We just heard from Dr. McDonald on his perspective on the role of public health in empowering New Yorkers to live healthy lives, including efforts to address barriers to care that patients may face in achieving whole person care and investments needed to improve equity, affordability, and access. I'd like to get your perspectives as well, but before we jump into the discussion, as a reminder to the audience, to submit a question, please use the Ask a Question function on the conference app. Now let's go to the questions. With that, each of you may have a different perspective, but what role does public health play in empowering patients toward good health, and what are some of the barriers to empowering patients to take control of their health? And I'm going to start with Assemblymember Paulin.
Thank you so much, and thank you for inviting me to be part of this. Public health can be thought of, and I know we're going to get to some of this later, in a very broad way, but I'm going to start with the narrow way, and that is, educating people to understand what healthcare means. What are some of the terrible things they can do to their bodies, and yet at the same time how they can get out of that. Tobacco control is one that comes to mind. So educating people is really, really critical. And the biggest barrier to that is how is best to do that? How do we get that information to patients? So often in the legislature, we fund education programs. But if they're simply going to be on the department's website, no one's going to see them. If they're simply going to be, frankly, at the county health department's local website, nobody's going to see them. So how do you get that information to a person so that they can internalize it and use it, so that they can really quit using cigarettes, so that they can really make the best decisions for themselves when they're about to have a baby? That's really what we need to think about, and the world has changed in that regard. So we need to constantly be thinking, how are we going to update that educational access? And I think that in a very narrow sense is a very important going forward initiative.
Thank you. And Neenah, you're out in the field. Tell us your thoughts.
Good morning. So I think as a person that works directly with low-income and marginalized communities, I think what was just said, education is probably one of the largest pieces, but not just education, but really meeting individuals and families where they are and addressing the whole person, the whole family, the whole community structure. I think when you're looking to educate the community, because what we see on a daily basis is some of the barriers to that education. Of course, there's education online, websites and things of that nature, but I think a lot of times people will scroll right past that. And so the public health system, to really begin to address a lot of the misinformation or misunderstandings that occur in communities that we serve, is a big, big barrier and something that really needs to be looked at. Most of the communities that I work with, they will go to WebMD or TikTok before they will ask a health provider or seek out medical attention. So finding ways to bridge that digital content or that digital divide, but as well as focusing on the full families. A lot of the individuals that we serve also may partake in unhealthy habits. But a lot of times, as we know, unhealthy habits are some of them can be very addicting, as well as much cheaper or easier to access. So I think the public health system should begin to look at, how do we not just put out initiatives that combat, one area or other, but how do those people access that and can make those healthy changes within their lives?
Thank you, Neenah. Sarah?
Yeah, and the public health system in New York State and other states is vast, but I'm going to talk from the perspective of the local health departments. It's not only education, right? Our members are going out. They have health educators. They're going into communities. They are talking about why it's important to get immunized, how to bring your newborn baby home and to have a safe and healthy start to life. We're talking about harm reduction, that everybody should be carrying naloxone, and this is how you do it. It's not only about the education, though, right? It's about having conversations and, like Neenah said, meeting people where they're at. What are your concerns about getting this vaccination? What is the barrier? And local health departments have a lot of data. They know the evidence base, so they can kind of help to have initial conversations, keep those conversations going, and then move people toward making their healthy decisions on their own and feeling really empowered. Once people are sick and they're in the hospital, they lose control, right? Now it's in the doctor's hands. The doctor has to take care of me. Public health is prevention focused, and it allows people to make their own choices about living a healthy life. And I think that that's really it makes people feel good about themselves when they can make informed decisions and then share that information with their family and make recommendations. Hey, I got my vaccine and I'm feeling pretty good. So I think it's not only education, it's definitely having a conversation and finding out where people may have questions, concerns, barriers.
So, Sarah, I'm going to kind of jump on the next question. It's going to be for all of you, but given that you're working with public health officials a lot, what are some of the barriers that public health leaders and community organizations face to improving overall health of New Yorkers?
Barriers. So, okay, I'll give you two. The first barrier is how public health has traditionally over time been funded. It is a boom and bust cyclical trend of, okay, there's a problem, let's fund public health. Then we roll it back, right? So an example of this, in 1999, the CDC issued a bioterrorism funding stream called Public Health Emergency Preparedness Contract, where they started an investment of about $30 or $40 million, putting it out there to get localities ready to be prepared for these types of emergencies, okay? 9/11 happened, and that exploded. We saw a jump from that $40 million investment to $1 billion of investment. We need to make sure our emergency system is prepared to handle these emergencies. 9/11 just happened, let's get this money out the door, done. Okay, 2005, we're seeing since 2005 to date, that same funding stream that we rely on for emergency preparedness has decreased by 42%. And that is one of the many reasons I feel that we're not as prepared for a pandemic with the magnitude that COVID had during that time. It doesn't allow us to make sure we have the workforce in place, right? That system has to be there. It has to be strong. It has to be effective. It can't be a boom and bust cyclical trend of funding public health. And so that's one of the challenges. The other challenges is, maybe anybody can tell me, how do you know when public health is working? How do you know? Exactly, you don't hear about it, right? No one talks about public health when the public health system is working. But when it's not working, it's front page in the news. And so we as public health practitioners, and this may be something that I think the health insurance plans could with actuarial staff and data experts could help us with, thinking about the return on investment that public health can have for our health system.
Thank you. And Neenah, as a community organization, what are some of the barriers that you're facing?
Well, when we look at, as a community leader, what I see on a daily basis really is the impact of not just looking at public health in a silo, but really addressing the needs of the full family. So when we work with individuals, if it's to help them move towards upward economic mobility, or if it's to improve their quality of life or access to health care, a lot of times what we see as challenges are addressing some of those other basic needs. So when we have an individual that may be a parent and their child does not have a medical home, or their child does not have access to dental care, a lot of times our families will look at that as a lower priority because I need to find stable employment, or I need access to healthier food choices and things of that nature. So a lot of the barriers or challenges that we face are really getting the families to not just prioritize healthy living or follow good public health qualities, but to really address some of those basic needs, as well as funding limitations. Organizations like ours, unfortunately, we don't, like the commissioner said, we don't get a lot of money. Mm-hmm. So having to rely on grant funding and all of the red tape and stipulations that go along with that, a lot of times we find ourselves in positions where there might be innovative initiatives or that we might want to try, but there's just no funding available. So partnering could be a solution to that, but there's a lot of funding limitations.
So we'll then hand this to Assemblymember Paulin, and who deals with a lot of the policy and funding.
So I'll say two things. First, the overarching problem we're having right now in healthcare overall is a workforce shortage. And that is a public health crisis that isn't being addressed in a comprehensive way. We have, as a legislature, I hear only about the money. You know, somehow if we increased everyone's salary, we're going to make more nurses. Somehow if we increase everyone's salary, we're going to make more doctors. Somehow if we increase everyone's salary, we're going to be able to hire more med techs, et cetera, et cetera, et cetera. It can't always be about money. To the commissioner's point, we need to think about the systems and what we've created and start to think more efficiently. For example, hospitals. You know, I recently sat next to the head of Northwell Hospital, and he was talking about how their initiative, they're going out in the community. They're going to have more community based. They want to take, they want to use less beds. Beds are expensive. And it just resonated with me that that's exactly what we need to do in every single aspect of healthcare, including public health. You know, what can we do to use social media better? You know, when I'm thinking back, and we all have our own personal experiences with aspects of healthcare, and why we made a good decision. And yesterday, we're supposed to we have an assembly retreat, and we're supposed to bond, right? So we're supposed to bring up something in our past lives and share it. So I was looking in my attic, that's where my past life is, and I found a book, Our Bodies, Ourselves. Mm-hmm. And that was the book that I learned how to have a baby. I changed everything after I read that book. I changed my health practitioner, I went to midwives, I had home births. I was a real radical because of that book. And you know what? I had the best birth experience of anybody I know. So everybody learns and finds information differently, and I don't think we do enough innovation and, frankly, enough partnerships, which I know is you know, an aspect that you want to talk about later. You guys play such a critical role, and I don't think you do enough. You think you do, but you don't. And the reason I say that is recently, for example, I had a meeting because I'm very interested in maternal mortality, obvious from that original book I read 100 years ago. And I brought together plans to say, you know, how can you be involved better? And found there was gaps. You didn't get the information you needed. Well, how come I had to have that meeting to find that out? How come every single initiative, the barriers for you to do your job, I as a legislator are completely unaware of? I can't know what they are. So for you to be better partners with health practitioners, you have barriers. That's not money. That's perhaps legislation, but it's also initiatives together with your partners to figure out how to go forward in a different way. Because this year, we're not going to have money, just the way it is. Some years we have money, this year we're not going to have money. So anybody who wants to come for money, you're not getting any. We have to just pray there aren't a lot of hits in healthcare, frankly. So we're having I'm announcing now, but we're having a workforce shortage hearing on December 19th in the city. And I know I'm going to hear all about money, but I'm going to ask every single panel, what else? What are the other things we can do this year? Because, you know, as was pointed out, money comes and money goes, and this year's hot thing is not next year's hot thing. And unfortunately, we don't have planning for 5 years. We have planning for 1. So when you have planning for 1, the new hot thing gets the money, and the old hot thing loses the money. So it's just the way, unfortunately, it works. I've been in government a long enough time not to be able, I can't fix it. I don't think anyone I know can fix it, but there's always a new hot thing. So we have to think this year on what we can do together as partners, and you are the overall partner, to get some of those initiatives done.
That leads right into the next question, really talking about thinking differently about investments. Many public health interventions like anti-smoking campaigns, which you mentioned, vaccination outreach as well, have shown to save money. And some have cost-effective ratios better than others and are equivalent to healthcare interventions. So what are some, how do we kind of look at those investments differently? And sometimes you have to spend money to save money in order to realize a return. So I'd like to ask you, and anyone can answer first, but what are some of the barriers to investing in public health? And how should we be thinking differently about those investments? Neenah, did you?
I'm not sure I'm the best person to talk about the interventions for public health,
Okay.
since that's not necessarily my area of expertise. However, I will say that looking at it from a community lens, I think that, when we talk about return on investments, especially in different communities and sectors, it's not always going to happen overnight. So what might be the hot thing this year may need to take a few years to really start to see the changes within the communities, within the neighborhoods that we are expecting to achieve through those investments, as well as understanding that things don't work in a silo. So if you're going to target certain investments or certain initiatives, start to look at how others in the communities or the other organizations or other entities within the healthcare systems may be able to help partner and leverage some of those investments, and how it may impact other areas of concern and how you may bring together those resources. Because one thing as community leaders that we are really good at is partnering and leveraging and matching resources. And I think that the healthcare sector can learn from that and do a little bit more to do that.
Thank you. Who would like to go next?
I'm happy to. So, when I know that question is supposed to be like, oh, if we could prove somehow tobacco control or any public health initiative saves money, the legislature is going to be more willing to fund it. Not true. I'm saying if it was going to save money this year, that would work, but it's not. We don't take long-term views, not usually, when it comes to money. It's a good fact to know, but it's not necessarily going to motivate the change. And I don't look at these initiatives, making someone's health better, quality of life. I don't think of it in terms of money, absolutely. Obviously, it costs money and we have to be more efficient. But being healthy and not dying at age 30 or age 40 and getting lung cancer because you smoke cigarettes, we want you to live to 80. Your children want you to live to 80. Your sisters and brothers want you to live to 80. At 80, you're still going to be expensive. That's when you access health care. So I don't look at it. I don't know. Maybe you're going to get a worse disease when you're 80 and cost a lot more money. I don't think of it like that. And as a legislator, I can tell you that it's better to bring that person who at age 40 had lung cancer and how horrible that was on their family. Bring that person to us. That's the personal touch. That's what's gonna make and motivate someone. You know, I remember when, way before I was a legislator, it was in the early days of Bring Your Daughter to Work Day. And I always did advocacy, and I was the president of the League of Women Voters, and we were advocating for the first restaurant ban in New York State, in Westchester. And I took my daughter to a hearing. At the hearing was a guy with a voice box because he had lung cancer or throat cancer, whatever it was that would have required that throat box, I guess, of throat cancer. And oh my goodness, my daughter, you know, she was maybe 9 or 10 years old, you know, she'll never smoke a cigarette. If you told her at 9 or 10, you know what, you're gonna save money, you know, because you're not gonna buy those cigarettes, it's gonna be cost effective for you as an adult, you think, but that voice box, so that's how we have to think, I think, about public health. You guys have a quality of life aspect that I don't think is capitalized enough, but that I think resonates to humans, resonated to my daughter, resonates to me. The quantitative cost analysis, you know, I'm not sure is, yeah, if I already bought in, it's good, it's a good talking point, but that's really all it is to me.
Sarah?
I would really suggest that we need to change the way that we're thinking about funding health on a national level and at the state level. The last time I looked on the national level, the last, out of the total healthcare expenditures nationally, and this very much trends the same way in New York State, we spend about 5% of that on prevention before people get sick. The rest goes to Medicaid, it goes to direct clinical services. And now I'm not saying we should stop funding hospitals or providers, absolutely not. But maybe if there's more equity and parity between those two facets, we can keep people healthy longer. We can keep people out of the hospital. We can address social determinants of health. We can address public health and core public health services and help people to live a long and healthy life and reduce those expenditures. So I would implore everybody to think about that. One of the things that I've learned is that Nebraska, totally different state than New York. I'm not comparing Nebraska to New York State, okay? But I'm hearing that every single one of their Medicaid managed care organizations are funding the local health departments in Nebraska to do core public health work. So giving immunizations, doing healthy family work, doing education, lead prevention, all of these great things that will really prevent people from getting sick in the first place, and they're paying them in Nebraska. Now, granted, Nebraska has 6 Medicaid managed care organizations, and New York has, I don't know, what, like 20. It's a very different system, and I recognize that. But I'm keeping my eye on these innovative models that are happening in other states and seeing if we can't get there at some point. So we really do need to shift thinking and prioritize prevention and public health and keep people healthy.
So I have a question here, but given what you said, Assembly Member Pollan, about money, and I appreciate that, I want to change the word investment to priority, okay, so that we can think a little differently. So what role does prioritizing social determinants of health play in empowering patients to achieving whole person care?
So of course, you know, the commissioner pointed this out, it's critical. You know, if you don't have housing and you're living on the street, obviously you're gonna have health issues that are exaggerated compared to someone who has a home. If you don't have food to eat, if you don't have those if you have violence in your house, you know, those kinds of things, you know, you are at a much greater health risk. Having said that, I don't know how much, you know, a local health department, considering what they already do and what they already could do with those subjects that they already take on, can achieve that. So yes, as a community, we can think, yes, we have to think about housing, we have to think about feeding people, but to simply give it another responsibility to the local health departments, they can talk about it, but I'm not sure they should be responsible for doing anything. You know, when I was immediately prior to being a legislator, I ran an agency for domestic violence victims. And and it's still a conversation. The domestic violence community feels very strongly that domestic violence should be considered a public health problem because it's violence in the home for the same reasons that no food or all the other social determinants of health. And you know, if you're getting beaten up every day or you're fearful, you're going to have much more of a health risk. But you know, we've chosen to think about domestic violence outside of public health for the most part. And I don't know that it's working. We still have a lot of work to do. But I just don't know that the public health departments can tackle that. I think they can speak about it, but tackling it is a much bigger job. You know, recently there was an article in Science Times. I love that section. And there was an article about loneliness. There was a new study that showed that loneliness is now a big factor. And of course it's a big factor. But it showed that if you're lonely, everything else, every other, you're going to be more likely to get all kinds of diseases and everything. And we know older people, when they lose their loved ones, you know, so it's not, you know, they have housing, they're eating, they're doing everything, but they're lonely. So, you know, is loneliness now something that we should, you know, who should we give that to? You know, the governor, you know, made a czar of loneliness, whatever that person gets to do. But, you know, who's responsible now? Mental health, public health, the doctor that you visit, like who's responsible? We just know someone should be. And maybe then that does resort, unfortunately, to the public health system because they are, over time, they've taken all those health issues that nobody else does. So maybe loneliness, because I can't think of a natural place for it to go, will fall on the backs of the health departments, with no funding, of course. But we're always learning about a new social determinant of health. They're intuitive once we know about them, but we have to think of a home for them to be able, for us to, as a society, to be able to battle.
Neenah, the role of community-based organizations in addressing social determinants of health and you know, what that means to really supporting whole person care.
Yeah, so, you know, with organizations like ours, we've been working in the framework of the social determinants of health for quite a long time now because we understand the barriers that especially low-income communities and communities of color face, especially when we're trying to create stable, healthy, supportive family structures within the state. So social determinants of health, which I would agree, it has to be a all in. So all sectors need to really be working towards how do we bring that together? How do we leverage resources? How do we begin to address some of the common issues and build partnerships that will foster how do families begin to meet their needs? Because one thing I see when we talk about public health, or we talk about the healthcare systems, and we talk about the needs of families, do we ask families? We probably do ask, but do they participate? So I think that one thing that we try to do is to bring in partners, bring in other types of services so that parents or the families or individuals in the communities know the opportunities they have, know the other resources out there that are available, and be able to have a stake in how they want to live or how they want to address healthy habits or prevention and things of that nature. It's just kind of like the commissioner said, nobody wants to be told what to do. They want options and be able to choose what they think is best for their families. And so using the determinants of health, not only can you help families identify and address some of the other issues that may be plaguing them, that might be contributing to why they are experiencing certain health diseases or certain health issues, and how do they begin to combat that? And community leaders can help build that trust and be that reliable partner so that they're able to say or able to come to places like us for education or knowledge or helping support to navigate the healthcare systems, which then would hopefully bring down some of that cost.
Neenah, thank you for bringing up one of probably the most important foundational words to address this issue is trust.
Trust.
Who are the trusted partners, which could be a provider,
Absolutely.
which could be a public health office, but is more likely a community-based organization in addressing some of these things. So I appreciate you bringing that up. And just to move on to, some of the things that Dr. McDonald talked about with respect to disparities in health equity, which, is a very broad conversation, but we don't need more studies to show the disparities, right? We need to figure out how to address those. So want to ask each of you to kind of provide your responses to those kind of big issues of how we actually do, we understand there are disparities, we know there are, how do we address that? Sarah, do you want to start?
Yeah, happy to. I appreciate your last comment, Neenah. Local health departments look at health equity, but we cannot address health equity fully without those partnerships, like the groups that Neenah is running, like LGBTQ pride centers that are in the community, barber shops, bringing in key religious leaders, people who really have that established trust. And even though the mission of our members is public health, let's be honest, we've been politicized. We are a local government agency, right? And there are some really big reasons why there's mistrust in these communities. And so to have a key trusted partner help us to promote the public health message and why it's so important is really, really powerful. We cannot do this alone. So addressing health equity in communities, some of the things that we're doing, we're hiring community health workers. Community health workers represent the community. They can talk with the community. They can go out and provide them with harm reduction supplies. They can give them naloxone. We can go out and we can talk to them about the services that local health departments offer. And then one other thing I just wanted to say in this realm is nemawashi, right? Neenah talked about getting feedback from the community and allowing them to help inform that, right? Nemawashi is a Japanese term that I learned, and it really means having everybody's input put into a program so that there's buy-in when you're rolling it out and executing it. We can't do anything without support from communities and hearing them and taking a moment to listen to what their needs are and then acting on that in a data-informed way. So health equity is definitely at the top of mind. It's something that you all, I know, are dealing with because Eric mentioned it last night at dinner. So, I agree it's powerful, and it's even more powerful when you're doing it in partnership.
So I completely agree. And I think I have nothing to add in that regard, except I will mention one other opportunity that I have as a legislator to equalize healthcare. And I'm sure there are other areas as well, but I'm thinking of vaccines. When you inoculate someone, a young person, you enable them not to get the disease. For example, HPV. It's not a vaccine that we require, but it would equalize healthcare, and we have a disparate number of Black women who are in this state who are getting ovarian cancer. So there are opportunities that I have as a legislator. They're not popular, or at least that one's not popular, but that would help also equalize healthcare. So when I look at legislation, I look at it through that lens, because some of the initiatives that we can do and take and pass do equalize healthcare. For example, we just, one of the bills that's pending before the governor changes the way we physicians do glucose tests, similar to vaccines. You do a test on an infant, you detect something. Well, when it was optional, no one did it. So now we're going to change it to mandatory, and that will equalize healthcare. So we'd love help on some of those initiatives from all of the healthcare partners to help us achieve these things.
I agree with both ladies on the stage. The only thing I would probably add to helping to address some of the disparities in different communities in relation to health and public health or access is to, yes, begin to engage and hire individuals within those communities, not just in, we have one person from the community working in our organization, so that's the person, but really make conscious efforts of bringing in those trusted, reliable faces from the communities that you're trying to reach, and have them help get those messages or build that trust within the communities or the populations. And then two, create facilities that are equitable. So healthcare facilities should be equitable in every community. There shouldn't be communities that are afraid to go to the hospital because they know the service or the perception of the service is terrible. And so communities spread words of mouth or just, talk. Communities of color identify places where they feel safe and not safe. Mm-hmm. And that might be the only facility that is in their area that they have access to. So if we're going to talk about creating facilities in communities that may have inequity currently or disparities, to really focus on upgrading, creating better facilities, creating better models of care that are culturally competent, and really address some of the systemic issues that these communities face, and not just talk about it.
Mm-hmm. So you all gave pretty, no,
You asked.
that's great. I mean, we should all be pretty passionate about this, and honestly not sitting down and standing up.
Yeah.
So I appreciate your emotion there. I have a few questions here, and I think this is, I'm not going to get to them all, but this might not be in our sphere here, because we're talking about healthcare, but what can we talk about in terms of using the public school system? To, like you talked about your 9-year-old daughter who saw something, how can we maybe infuse better health education within the public health, and do you think there's that has a role to play?
Well, I'll say, since the pandemic, the schools have become our best friends. We talk with them every day about different public health issues. I do look forward to seeing more collaboration between the state agencies. I know Commissioner McDonald talked about that and the partnerships he's making specifically with SED. There are some times where, we'll find out a letter went out to schools about public health and, maybe we weren't aware. So but the communication is going to get better, right? And so now we're working with them to make sure we know the trends in the school, like, hey, 30 kids called out with COVID, maybe we've got an issue, let's send some messaging home to parents, or just thinking about water, right? Making sure that the water fountains are lead-free and there are requirements in law to make sure that those are being tested. That's super important. So our local health departments, the environmental health sanitarians will work with the schools on that. So we are constantly providing and working with the schools to understand what is your environment like, right? And how can we help from a public health practitioner standpoint to make this a safe place? Because these kids are coming to school, and guess what? This is where they're getting their only meal of the day. So it's really important that they are there in a safe place, in a public health friendly place, and have access and are getting a good education, which is a social determinant of health. So there's so much we can do with schools, and I think it's really exciting. I also think there's an opportunity to get kids really excited about public health as a career, teach them about public health, even if it's just simple hand washing, building that into school curriculum. So great question, and yeah.
I would agree with that wholeheartedly. We operate Head Start and UPK, Universal Pre-K for Albany County, and one of our biggest initiatives is health. And when we service birth through 5, a lot of times it's their first interactions, the children's first interactions with healthcare systems that they can understand, from oral health to, this is my pediatrician. And more times often than not, we have to help our parents or other individuals within the families to access what is actually a health home. So many people come to us and don't have one. And so I think using and we also work within the school systems with other issues or initiatives. And I think that starting there and at least embracing that could be such an opportunity to create long-lasting partnerships. And you talked about prevention. Most individuals, especially if their parents want, even if they don't take it for themselves, they want what's best for their children. So to be able to begin at earlier ages to expose them to some of those interventions or some of those situations where they can learn and grow and create partnerships and foster relationships with health entities is phenomenal.
I'd like to leave the last couple of minutes for Assemblymember Paulin to maybe offer some thoughts about aligning some of the education programs to the healthcare programs, and if that's something you kind of consider as you in your health committee.
So do you mean in the schools or more?
Yeah, like healthcare in the schools and working with, education, because it's a separate area with a lot of resources too.
So first I'll take on the schools.
Yeah.
One of the problems we have in the school districts is, some of them are poorer than others, right? That's around the whole state. And some of them don't have nurses. So it's very hard for the school district, if they don't have a nurse, to deal with someone's physical health, never mind the mental health issues that our children are now facing. So, one of the legislative initiatives that we have before us, not in my committee, it's in higher ed, will allow the school districts to use telehealth. It's not currently allowed. It's allowed only if they have a school health center, and very few districts have that, mostly in New York City, almost none outside the city of New York. So we have to, but there's quite a lot you can do through that person in the schools. they would have a physical presence. They could be a link to the health departments. They know what the health resources are in the communities a lot better, but it's almost impossible to do if you don't have some nexus between the school district and the rest of the healthcare community out there. And that really is, I believe, the school nurse.
Thank you.
Well, please join me in thanking our panel, and to Roberta, thank you for stepping in. Assemblymember Paulin, Neenah, Sarah, really great conversation. So please join me in thanking them for this conversation.